Welcome to this explainer. I want you to picture two patients sitting side by side in the emergency room right now. They're both breathless, leaning forward, just trying to catch some air. They both have fluid crackling in the bases of their lungs, and their legs are visibly swollen. Look, on paper, from the outside, it looks like identical heart failure. It's a genuine medical mystery staring us right in the face, and today, we're going to solve it by popping the hood and looking at the mechanics of the heart itself.
But the mystery actually deepens when the echocardiograms come back. Patient 1 has an ejection fraction of 25%. Now, patient 2, however, comes back with an ejection fraction of 60%. By all the traditional numbers you'd normally look at to reassure yourself, patient 2 is totally completely normal. And yet patient 2 is failing just as badly as patient 1. Honestly, sometimes they're doing even worse.
Okay, let's really dive into this. Why are they both failing? Like, how can a supposedly normal number on paper lead to the exact same life-threatening symptoms? For decades, the drugs that quite literally saved the life of our first patient did absolutely nothing for the second. To understand why that is, we really have to look closely at the machinery underneath. Let's just strip away all the medical jargon for a second. At its absolute core, heart failure is simply the heart's inability to pump enough blood to meet the body's metabolic demands, or it's only able to do it at abnormally high filling pressures. It's a classic supply and demand mismatch happening at high pressure. And that single definition right there, that holds the secret to our two patients.
Notice how these shared physical exam findings map perfectly to a common downstream physiology. It's all based on retrograde pressure. A failing pump basically raises pressure upstream, kind of like a blocked pipe. On the left side, that pressure transmits straight back into the lungs. That produces tachypnea or thopnea, where patients literally have to sit upright just to breathe, and those bibasilar crackles you hear with your stethoscope. Now on the right side, the pressure transmits backward into the venous system. That's what gives you a raised jugular venous pressure, an enlarged, congested liver, and that deep pitting edema in the legs. You'll even hear an S3 gallop, which is just the sound of rapid filling into an already overloaded chamber. So you're seeing the exact same outward signs generated by the exact same backward pressure.
But here's where this shared presentation builds into a fundamental split in the machinery. You can fail to pump enough blood because the pump itself is weak, right? Or you can fail because the pump squeezes fine, but it just can't fill properly in the first place. This is where our two patients diverge. Patient 1 has HFpEF, heart failure with reduced ejection fraction. Think of it as a weak, dilated, flabby engine. Patient 2, on the other hand, has HFpEF, heart failure with preserved ejection fraction. Their engine squeezes just fine, but the walls are thick, stiff, and completely non-compliant. The chamber just absolutely refuses to relax to let the blood in.
Diagnosing this requires an echocardiogram and checking natriuretic peptides, or BNP, in the blood. BNP is released when the heart wall stretches. But beware the traps here, guys. The really crucial point is that BNP can be falsely low in HFpEF. Why? Well, because a stiff, thick-walled ventricle doesn't stretch the same way a thin, dilated one does. It generates lower end-diastolic wall stress. So you can easily have a patient with HFpEF who is highly symptomatic, sitting right in front of you, but has near normal BNP levels. You simply can't use a normal BNP alone to rule out heart failure.
All right, let's get into mechanism 1, the weak pump, or HFrEF. When the pump is weak, the body basically panics. It triggers these sympathetic and hormonal cascades that, ironically, end up accelerating the heart's decline. To stop this, the 2022 AHA, ACC, and HFSA guidelines outline 4 foundational pillars designed specifically to interrupt that maladaptive cascade. First, you've got an ARNI, ACE inhibitor, or ARB, to block the renin-angiotensin axis. Second, beta blockers to blunt that chronic sympathetic overactivation. Third, mineralocorticoid receptor antagonists, or MRAs, to block aldosterone-driven fibrosis. And fourth, this is the major recent addition, SGLT2 inhibitors, which have incredible diuretic-like and direct cardiac benefits, completely independent of diabetes status. Every single one of these pillars disrupts the chemical cascade that's actively destroying the weak pump. Now, beyond those core 4 pillars, we do have some extra tools for patient 1 if they have persistent symptoms or worsening episodes. We're talking things like ivabradine for controlling heart rate, hydralazine isosorbide dinitrate, digoxin for symptom reduction, and vericiguat for specific higher-risk populations. We also use intravenous iron to improve symptoms in iron-deficient patients. It really is a robust, highly effective toolkit. But wait, what?
Here is the multi-million-dollar question that stumped the entire medical community for years. Why did the exact same drugs that completely saved patient 1 fail patient 2? Why did those 4 amazing pillars do virtually nothing to save the patient with a preserved ejection fraction for literally decades?
And that brings us to mechanism 2, the stiff chamber, or HFpEF. This is the much harder problem to solve. See, patient 2 doesn't have a weakness problem, they have a relaxation and compliance problem. Well, HFrEF is fundamentally a neurohormonal activation problem. HPFF is a structural stiffness and filling problem. The drugs that rescue a weak dilated ventricle by interrupting that neurohormonal panic, they simply do not fix a thick, fibrotic, structurally stiff chamber. Mechanistically speaking, they're just attacking the completely wrong target. And that's exactly why ACE inhibitors and beta blockers consistently failed to show clear mortality benefits in HPFF across multiple major trials. But this is where the story gets incredibly exciting. For decades, pre-2023, HFpEF patients basically had no clear foundational therapies. It was incredibly frustrating for everyone. But then, rapid breakthroughs completely changed the landscape overnight. In 2023, the ESC guidelines officially recognized a massive shift. And then, just recently in 2024, the Fine Arts HF trial established another absolute game changer. Let's break those down. In 2023, SGLT2 inhibitors earned a Class I recommendation across all ejection fraction ranges. The ESC guidelines made this incredibly, abundantly clear. Dapagliflozin and empagliflozin were shown to significantly reduce heart failure hospitalizations and cardiovascular death for HFpEF patients, regardless of whether they had diabetes or not. Literally overnight, HFpEF went from having 0 foundational therapies to having its very first definitive pillar, a real game changer. And the hits just kept coming. Comparing therapies reveals this massive leap forward. Steroidal MRAs, things like spironolactone, they had an inconclusive mortality benefit for HFpEF for years. But the 2024 Fine Arts HF trial looked at finerenone, which is a non-steroidal MRA. The trial conclusively proved that finerenone successfully reduces heart failure events and cardiovascular death in HFpEF patients, even if they were already taking an SGLT2 inhibitor. So boom, we now have a groundbreaking new second pillar for our stiff chamber patients. Now, I just want to pause on this number for a second. 40 to 49%. This is the mid-range ejection fraction known as HFmrEF. For a long time, it was kind of this confusing gray area. But current guidance, strongly backed by these new trials, increasingly treats this mid-range much more like HFpEF. These patients also see massive, undeniable benefits from these 2 new drug pillars we just talked about. Of course, with HFpEF, the 2 drug pillars aren't the whole story. Because it's a structural problem, we have to aggressively treat the underlying drivers that damaged the pump in the first place. You can't just throw pills at a structural issue. That means aggressive hypertension control, which is the most common cause by far. It means strict weight management. Actually, drugs like semaglutide have shown genuine quality of life benefits, specifically in obesity-related HFpEF. And we also have to manage obstructive sleep apnea and maintain tight glycemic control. So let's pull all this back together. Our 2 patients sitting right there in the ER with identical symptoms need totally different toolkits. The patient with a 25% ejection fraction has a weak dilated pump and desperately needs those 4 foundational pillars to stop neurohormonal damage. The patient with a 60% ejection fraction has a stiff fibrotic pump. They need the 2 new pillars, SGLT2 inhibitors and finerenone, plus super aggressive control of their underlying drivers like hypertension and obesity. I want to leave you with this absolutely crucial thought. A normal number doesn't mean a healthy heart. The next time you see a preserved ejection fraction on a report, really try to resist the reflex to feel reassured. Identical symptoms mean identical failure. But understanding the totally opposite machinery underneath is what actually saves lives in the end. It makes you wonder, if a normal test result can successfully hide a failing machine, what other medical assumptions do we need to look past to uncover the truth? Thank you for joining me on this explainer, and keep questioning what's beneath the surface.